Hello, everyone. This is Dr. Cross, and this week we are covering neurodevelopmental disorders. I decided for this week to use a child welfare PowerPoint from the University of Pittsburgh. It's more, this PowerPoint serves more as a resource for parents, but it does a good job outlining some important things you need to know about neurodevelopmental orders. This is actually a larger, more comprehensive PowerPoint that includes other mental health disorders such as PTSD and anxiety, depression, and a lot more. But for this week, since we're covering neurodevelopmental disorders, I'm only going to review a portion of this PowerPoint presentation just because I think it does a really good job illustrating um, neurodevelopmental disorders in a child welfare context. So it not only talks about the disorders and the key features of them, but it also talks about how to work with families who have children with these type of disorders and the type of treatment that needs to be offered in a culturally competent and sensitive way. There's a significant portion of the country, the U.S. specifically, that deal with mental health disorders. Um, 11.3% of U.S. children ages 2 to 17 are reported by their parents to have been diagnosed with emotional, behavioral, or developmental condition. ADHD is the most prevalent diagnosis among children between ages of 3 and 17. So again, when you think about the whole total U.S. population of children between 2 to 17 years of age, we're looking more into 11%. And as this is self-reported by parents, it's important to note here that these are parents that reported these problems and knew there was an issue. It is a possibility, a high likelihood actually, that this number is underrepresented. It's a lower um, number than probably what the actual number is, because there are many children that may be suffering from these emotional, behavioral, and or developmental conditions, and the parents are not aware of it. So even though that we're looking at 11% of U.S. children, this may be a conservative estimate. We do know that ADHD, attention deficit hyperactivity disorder, or attention deficit disorder, is one of the most prevalent for children. If you look at a lot of the literature and research on ADHD, boys are more likely than girls to have ADHD. We also know that behavioral or conduct problems are also associated with ADHD. We also think about how children manifest behavioral, emotional, or developmental issues, and oftentimes they will show themselves in behavioral or conduct form. Children are not as advanced conceptually, cognitively as adults. And so a lot of times when there is a disturbance going on with them, they will display this in a behavioral way or a conduct problem. Parents may realize this first, but it's not just in the home system that these behavioral and conduct problems can occur. Oftentimes they're also located in the school system as well. And so teachers and officials at the school are on heightened awareness when children present with behavioral or conduct problems. And even though most likely professionals that are not trained in mental health will think that the issues that are presenting are just behavioral and or conduct problems. And they oftentimes fail to look for a more deeper or root of the problem, the root of the behavioral and conduct problems. More sophisticated, more advanced settings, health school system settings, will run screens to make sure that the behavioral or conduct problems are not rooted in a mental health disorder. Another profession that's really good about identifying uh, the root cause of behavioral conduct problems are pediatricians. Sometimes they are trained and um, more cognizant of potential behavioral and mental health problems that children may be experiencing. We're not covering neurodevelopmental disorders for this week, but just as it is listed here, When you're thinking about depression, girls are more likely to be diagnosed with depression. And suicide is the second leading cause of death among children aged 12 to 17. We'll be covering depression and suicide later on in the weeks for this course. As we will be focusing on neurodevelopmental disorders, this PowerPoint covers autism as well as attention deficit hyperactivity disorder. One way, or the main way, in identifying and diagnosing ADHD, attention deficit disorder, or attention deficit hyperactivity disorder, and autism spectrum disorder is through a psychological or psychiatric evaluation. When a psychological or psychiatric evaluation occurs, the provider is most likely using the Diagnostic and Statistical Manual of Mental Health Disorders. In order to have a legit official diagnosis, the DSM-5 must be used. One thing to be mindful of the DSM-4, it does list the disorder, and it also has the main categories of the disorders. Disorders are arranged across the lifespan in the DSM-5. Another thing that the DSM-5 has done a better job doing in its most earlier version is taking into consideration cultural context. And even if the DSM-5 did not consider this, the clinical provider who is providing the diagnosis must do this. And so you need to make sure that the behaviors that are being presented, or the emotional or symptoms that are being displayed, doesn't have a cultural context in which to embed it in. And in this way, you're making sure that your diagnosis is as accurate as possible. We talked earlier about what is a problem. How do we consider a disorder? What do we think of as abnormality? Well, one key piece of this is understanding the cultural context. Is something abnormal in a specific cultural context? And in what ways do you justify a diagnosis? And how do you account for the cultural context in your diagnosis? Also, when diagnosing, you want to make sure that you identify the frequency and intensity of emotions and behaviors. It's not enough just to have a symptom or have several symptoms, but you want to get an idea of what is the frequency as well as what is the intensity, what is the scope of the problem. Sometimes by identifying the frequency and intensity, you can get a better idea of how well that client is functioning, and or if that functioning is impaired and by how much. So please be mindful that when you're thinking about diagnosis, and particularly your case assessment and case analysis, you want to think about not just what are the symptoms that are presenting, but you also want to have really critical thoughts about what is the cultural context in which those symptoms are occurring. And based on the cultural context, are those symptoms abnormal? You also want to be very clear what is the frequency and intensity of any symptoms, emotions, or behaviors that are being presented, because this will key you into how much that particular client's functioning is being impaired. There are several types of theoretical perspectives in which to view disorders. One is the biopsychosocial model. The biopsychosocial model is very comprehensive. A few of those areas are listed here. And when you're thinking about neurodevelopmental or neurodevelopmental disorders, you want to think about the temperament of the child or the client. Is that temperament easy? Is that temperament difficult? Is that temperament slow to warm up? You also want to think about those environmental factors. What are some of the key environmental factors? Well, if we're talking about a child and neurodevelopmental concerns, you want to think about the family dynamics. How is mom relating to father? How is the father relating to mom? If it's a nuclear family, you also want to think about how the caregivers are interacting with each other. If it's a same-sex couple, you want to know if this is a divorced family system. You want to know if this is grandparents caregiving and what those dynamics are in that household in which that child lives. You also want to get a sense of the parenting styles because the parenting styles will determine how caregivers react to any type of disorder that's identified through diagnosis. You also want to consider the larger social systems in terms of the schools, potentially religious systems such as churches, synagogues, mosques, perhaps. Also, when you think about the larger systems, you want to look at all those larger systems that the child may come into contact with. As I stated earlier, school system is a big social system, and where students spend a lot of their time. Others, healthcare providers, and so forth. This can be summer camp and other extracurricular activities as well. So you want to see how a potential disorder is playing out, and you want to consider the family dynamics and how that family, the issues in that family, or how the family relate to each other may impact the disorder and the symptoms. You also want to think about the parenting styles and how those parenting styles will influence how that particular child gets support or not get support, how symptoms can improve or how symptoms can be compromised. You also want to know the larger social systems and how they um, exacerbate potential symptoms or can be a support systems for that system. And you also want to think about adverse life stressors. When you think about neurodevelopmental disorders and a child, you want to know if there's additional stress that may be going on for that child. As stated earlier, maybe divorce, maybe multiple transition if the family's moving a lot, maybe the loss of a family member. All those things constitute adverse life stressors that that child may be going through. And you also want to consider genetic and physiological uh, areas as well. Again, the biopsychosocial models looks at all these different areas and more, but for this presentation, these areas are being targeted. You want to see how well that child is predispositioned to have genetic concerns or physiological concerns. And a lot of times you can do this through um, a genogram. You also want to consider some physical health. As I stated earlier, a lot of primary care doctors, pediatricians specifically, are very good at um, highlighting when there's behavioral emotional problems and locating the root cause of it. But one thing that they will definitely do is make sure they rule out any physical health concerns first. Because sometimes there may be physical health conditions that are going on that may be contributing to the emotional behavioral problems or conduct concerns that a child may be experiencing. And you want to make sure you always rule out the physical health conditions first before moving forward to making a more firm mental health diagnosis. Another key area that you want to consider is resilience. Resilience is a dynamic process encompassing positive adaptation within the context of significant adversity. Resilience is a very strong tool and oftentimes is not as assessed as well or documented in patient charts or client charts. But it is very important to make sure you highlight any resilience. We in the School of Social Work here like to always be very clear what a client's strengths is and what are some of the factors that play into their resilience. Resilience is important, particularly in the mental health field, because we want to make sure that we highlight those areas in which a child, specifically a child dealing with a neurodevelopmental issue, may be adapting in a positive way to their symptoms or to their disorder. And you also want to identify how the strengths of that child helps propel them through the adversity of the disorder and or diversity of any of the things that may be going on in their systems as such as identified in the biopsychosocial assessment. When you think of resilience, you're looking at nature and nurture. You're looking at resilience factors that may be genetic or genetically handed down from child to parent, family to child. Um, but you also want to look at the nurturing aspect. Again, what are the family dynamics specifically? What are the family supports for that child? What are the parenting styles? How is that child being nurtured through these neurodevelopmental challenges? And you also want to think about the risk factors and the assets. When we think about risk factors, we're talking about what are some of the things that can exacerbate or make the symptoms worse. And what are some of the assets? When you're thinking about assets, you're thinking about family support, you're thinking about income, socioeconomic status, you're thinking about community resources. All these things we use as tools to improve the client situation, but sometimes these things can be risks as well, and we need to be clear with that. Once you have these assessment complete with resilience identified, it then makes it easier to develop a plan. And the plan will account for the risks, but also utilize the assets and strengths of a particular client, specifically related to resilience, to help them overcome the challenges that they're dealing with. I think it's important to note that even though in the assignments for this course we talk about what assessing and diagnosing clients, we also talk about coming up with treatment plan and considerations for each client and keeping a cultural competent lens related to assessment and diagnosis as well as treatment. But what I think it's important to mention here as well is that even though we know a significant amount of children are dealing with mental health issues, we know that about half of children with mental health issues are not receiving treatment for it. We know that social workers are needed to advocate for children with mental health issues. Children have a right, all people, but specifically children have the right to access treatment, and that treatment means assessment and proper assessment and diagnosis, and making sure that they have the treatment that they need, and it's evidence-based treatment. We also want to make sure that the treatment that they receive is adequate. Now, when you think about ethical behavior, ethical practice, we're talking about sufficient treatment in terms of frequency and duration to meet their needs. When we're talking about treatment, we're also talking about, from an ethical standpoint, treatment administered by competent individuals and making sure that people who are providing care are working within their scope of practice and they're applying standardized care that is evidence-based. Social workers are highlighted as providing very good care to patients, but also they are sometimes the main voice and sometimes the only voice in treatment teams that advocate for clients. However, even though social workers are well positioned to do this, and I feel do it the best, the burden of advocacy does not just fall on the social worker. All team members must be advocates for patients and clients. When we think about neurodevelopmental disorders, there are many beliefs and ways in which a neurodevelopmental disorder can occur. When we're talking about neurodevelopmental, we think that a lot of neurodevelopmental disorders happen in prenatal. This means that a child may have complications during the prenatal period that may predispose them genetically or by way of prenatal exposure, increase their chances of having a neurodevelopmental disorder. We do know that there may be specific things that go on within that perinatal period or prenatal period that may contribute to a neurodevelopmental disorder in a child. There are research studies that look into maternal stress at any given time during a pregnancy that may influence or lead to a neurodevelopmental disorder. There are genetic concerns as well. There's a lot of research that's looking into maternal drug use as being a correlation between substance use and neurodevelopmental disorders such as ADHD. And one way that we know that a neurodevelopmental disorder is indeed present is through, again, proper diagnosis through a psychological evaluation. But oftentimes it's highlighted by either the family and or the education system because we see that a child is not meeting their developmental milestones. And when we talk about the developmental milestones, we're talking about language as well as cognitive development. Are there any concerns with that particular child's language, their speech, or their ability to vocalize? And is there deficits there or impairments there, as well as cognitive development? And that is why oftentimes schools are really good at identifying these things, especially as that child is being measured and compared to their peers. We also know, in particularly in our social work course, that we study cognitive development, and in your human behavior course, we're looking at how individuals develop properly in the human behavior and the social environment. And understanding the stages of development, whether they're cognitive or physical, will also help you know when there may be a neurodevelopmental concern there, because you'll know that that particular child is not meeting their appropriate developmental stage. As I stated earlier in the biopsychosocial model, that you want to look at all the systems that the child is involved with and how those systems may impact development. Family stability is key in terms of trying to determine if there are any environmental risk factors for development. If there's a neurodevelopmental concern, there's a belief that something has happened prenatally to impair the development, the cognitive development of that child. But we also have to consider how much after birth or when that child is growing up in their home, how many external factors are compromising that development at that point. Family stability is one, adverse events in that child's life is one, where that child is located in terms of resources, neighborhood. Are the daycare centers providing appropriate developmental stimuli for that child? And again, it's the parenting styles of that child enhancing the child's developmental output, whatever that may be, or is it compromising it? As neurodevelopmental disorders can be very complicated, and the biopsychosocial model is a very good framework of choice to apply because we know there's a biological component to the impairment. We also know that it will display itself in emotional behavioral problems. And we also know that that environment that that child is involved in will impact the outcomes. That makes the biopsychosocial approach a very good framework to use. Not the only, but a good framework to use. But once you use the biopsychosocial model to help assess what is going on and to help enhance the diagnosis, again, another tool would be a genogram. You understand the comprehensive nature of neurodevelopmental disorders. And in that understanding, a team approach to treatment is necessary. Because of the biopsychosocial nature of the disorder, you want to make sure that you have a team that's in place that can address all those areas in a competent way. And so a team approach to treatment with neurodevelopmental disorders, all disorders, but specifically neurodevelopmental disorders, you want to make sure that the parents are educated and have the support that they need to enhance the outcomes for that child. And that's resources to parents. You also want to, or parents and or caregivers, and you also want to make sure that you collaborate and incorporate the parents or caregivers in the treatment. They have to have buy-in. They must understand through psychoeducation what is going on with their child and ways to improve outcomes. You also need a caseworker um, and or a social worker, which social workers are very good at understanding things from a mental health standpoint, but also from a social standpoint. And to be quite honest with you, social workers also have to understand things that are going on in the biological standpoint, in the biological area as well. In order to help patients and support them and get them where they need to be, we have to understand clients through all levels of systems. As stated, a pediatrician is key in treatments for neurodevelopmental disorders, because you want to at least make sure you rule out health conditions, but also make sure that somebody is monitoring that development and making sure that child is meeting or helping them maximize their developmental milestones as much as possible. Psychologists and psychiatrists are important because, one, oftentimes they're doing the psychological evaluation, psych eval. Sometimes it's a clinical social worker. Um, but sometimes there's medication provided, which a psychiatrist would need to do. And again, the therapist, which usually is providing ongoing follow-up with the psychologist. And again, the therapist can be a psychologist or a clinical social worker. And there's also educators. These can be health educators. This can be psychoeducation from the therapist. And this can be educators in terms of the school system. You want to make sure everyone is on board and understand what's going on with that child to maximize support and improve outcomes for that child. As stated, neurodevelopmental issues can include impairments in areas of development. And so speech and language therapists, OT, PT, is important. Occupational therapists to help that child or adolescent with making sure they can OT-PT, making sure that the child's motor developmental skills are enhanced and that they meet whatever developmental, they're able to function in a way that's appropriate for their age. Even if it's not likely that a particular child with a neurodevelopmental disorder will be able to meet um, the the PTOT needs for their age. The whole point is to maximize their output, and you want to make sure that they are provided with the supports to have the best outcomes possible, giving their disorder and what that disorder looks like for them, and what impairments that particular child may be experiencing with their neurodevelopmental concern. And so, as a team approach is ideal when thinking about the biopsychosocial model, then all members play an important role in gathering and sharing information. And all team members are sharing information related to strengths, challenges, needs, and underlying issues. And this is strengths in the biological area, strengths in the psychological area, strengths in the social area. Similar with challenges. You want to know what the challenges are in the biological areas, what are the challenges in the psychological areas, as well as the social areas. Again, with the needs and other underlying issues. In order for a child with a neurodevelopmental disorder to have the maximum outcome possible, all members of the treatment team, their perspectives and their voices need to be heard. They all may have different interdisciplinary lenses, but those lenses are to meet a common goal, and that is to enhance the change process or to move forward that change process to improve the outcomes for that client. Similarly, all members must be culturally aware or should be culturally aware and responsive to the child and family needs. Oftentimes the team members are not, and I find that social work plays a key role in educating the team, making sure they maintain cultural awareness at all times. And as part of our social work code of ethics, all members are treated with dignity and respect the same way we engage with our clients. As stated, the two neurodevelopmental disorders we'll be covering quickly will be autism spectrum and attention deficit disorder. When you're thinking about autism spectrum disorder, the symptoms, we want to look in a couple of key areas. One is social communication and social interaction deficits, and the other area is restricted repetitive behaviors, interests, and or activities. When you think about social communication and social interaction deficits, you're thinking about social emotional reciprocity, to be able to receive an emotional response and respond appropriately with an emotional response, the ability to receive a social cue and to then respond with reciprocity to that social cue. We're also thinking about nonverbal communication behaviors used for social interaction. You want to see how they communicate in a nonverbal way and how they use that nonverbal communication to convey social interactions. And again, these are areas that you will find deficits and or impairments in. So social and emotional reciprocity, as well as impairments in nonverbal communication. Another area is developing, maintaining, and understanding relationships. You'll find huge impairments in a child with autism spectrum disorder in developing, maintaining, and understanding relationships. Again, restrictive and repetitive behaviors, interests, and or activities. These are stereotype, redundant, repetitive movements, or repetitive use of objects, or repetitive speech patterns, or stereotypes. Insistence on sameness is also key, and it's some of the reason why routines work best with children who suffer from or are affected by autism spectrum disorder. Fixated interest on objects, people, things. You will notice that as a key factor. Also hyper or hyporeactivity to sensory input. We know that for every 4 male children that have autism disorder, there's about 1 female, so 4-to-1 ratio. We know that autism is about 1% of the child adolescent population. When we think about the environment, some of the, as I stated, prenatal factors that may influence autism is advanced parental age and or fetal exposure to toxins. That could be substance use and or medication. Also genetic plays a big role. 15% of cases are associated with genetic mutation. And there is also research that suggests that multiple genes are most likely involved. There are providers that are trained. These can be social workers or psychologists that are trained in assessing and diagnosing autism. Pediatricians are also well versed in being able to assess and treat autism. Pediatricians are using screening tools for autism. These screening tools are occurring as early as 9 months up into 24 months. As of now, there is believed to be no known standard of treatment. However, applied behavioral analysis is the gold standard based on my experience in terms of treatment for autism. Now, every practitioner may not apply that standard. However, at this time, ABA, applied behavioral analysis, is the treatment of choice for many providers. Not all, but many. Because it's a comprehensive developmental disorder, you want to make sure that you have a combination of therapy treatments and responses to improve outcomes for that child. Behavioral therapy, educational intervention, medication when needed, to make sure that you treat the symptoms that are being reported by parents. And that could be such things as lack of sleep, temperament concerns, conduct concerns, self-harm concerns, and so forth. Some of the interventions used with children is making sure there's a plan in place to maximize support, decrease concerning behaviors, and we do this through IFSPs and IEP plans. They're usually implemented in school settings. Again, they're just a more formal plan to help address the concerns that are presenting at home and at school, and to make sure you maximize support for children who need special accommodation. Interventions also include adding an occupational therapist to help address sensory integration issues, as stated, providing structure and routine. Provide transition cues whenever you're changing from breakfast to lunch to snack time, from snack time to reading time, that there are specific cues that you put in place to help support that particular child. Motivating that child, being mindful of the sensory challenges that that child is having and not overwhelming that child or putting expectations that are not appropriate for that child. Also using visual icons as much, such as pictures, anything to help support the child and the child's needs. And also just make sure of the language that you use when working with children with autism disorder. You may need to do a little bit more explaining, as there may be some communication deficits with that particular child. ADHD. Primary features persistent patterns of inattention and or hyperactivity, impulsivity that interferes with functioning or development, or inattention and impulsivity. It needs to be present before the age of 12 and manifest in 2 or more settings. That would be, for example, family and home, family and camp, but you need 2 settings. There's 3 subtypes within this order: predominantly inattentive, predominantly hyperactive / impulse, and or combined. And again, some statistics: 5% of children / adolescents are diagnosed with ADHD. Girls most commonly diagnosed with the inattentive subtype. When we think about ADHD, there are again some from a biopsychosocial standpoint. There are some environmental considerations, low birth weight, which would fall within the prenatal, perinatal, environmental concern, biological, history of maltreatment or multiple foster placement, that will fall within the social spectrum. Drinking, smoking, toxin exposure, such as lead during pregnancy, again, perinatal, as well as social concerns, and genetic, when there are first degree relatives that have ADHD. How do we assess for ADHD? Parent report or caregiver report, as well as an interview. Potentially a child interview if it's appropriate, and the Conners rating scales completed by the primary caregivers and the teacher. When we think about treatment for ADHD, we're talking about individual and parent counseling to how best respond, how to address parenting styles, how to provide psychoeducation to that parent so they understand what's going on and how best to support their child. Academic accommodations, such as the IEP, as we talked about. Cognitive behavior therapy is a gold standard evidence-based therapy approach for ADHD. Social skills training. If we know that ADHD, as well as other neurodevelopmental disorders, compromise social skills, one of the things you want to do is help train those social skills. Again, the goal is to maximize outcomes for each individual child, and sometimes medications to help address the symptoms, such as stimulants and antidepressants. And this slide briefly talks about how interventions are performed depending on the different areas: inattention, hyperactivity, and cues. Inattention, one intervention technique is to only give one direction at a time and only when in direct proximity with the child. self-talk, positive self-talk messages to that child. In the area of hyperactivity, where we want to provide structured physical activity, routine, provide transition cues when necessary and as often as possible, and cues to use calming techniques, breathing techniques, um, tactile objects, touch a soft object. This helps with the sensory and centering. Bring knees to chest. This is calming, um, calming for children who have sensory motor stimulation. Excuse me. I will stop here. However, there are many different neurodevelopmental disorders that are covered in your textbook. Um, Intellectual disabilities is a major disorder and is also significant in the population, and that is worthy of review and paying special attention, as well as speech and language disorders as well. I will conclude this as this video is a little longer than the rest, and I'm trying to be mindful of your time. But make sure that, as always, this is just a way to help supplement your reading and review of the topic of neurodevelopmental disorders. I thought this University of Pittsburgh slide would be helpful in terms of a child welfare context and understanding the key issues related to neurodevelopmental orders. Also to walk you through some of the treatments for it and the assessment and diagnostics, some of the key players in treatment planning, assessment and treatment planning for neurodevelopmental disorders. And I hope this gives you a little flavor of how to think about your case assessment and case analysis. Thank you.